All right, let's get into reimbursement and payment for APRN services. There's 4 national initiatives accelerated interest in and necessity for APRN reimbursement. It's the IOM, the Patient Protection and Affordability Care Act, the Consensus Model, and the evolution of the APRN doctoral education. The history and the perspective of this. There was a national vision of healthcare system was first talked about by FDR and then Truman. If we go into the history, in 1965, Medicare was created to assist those older than 65. Physician services reimbursed using fee-for-service model. In 97, they came up with the Balanced Budget Act, which set the payment for APRNs at 85% of the physician fee scheduled. However, CNMs, nurse midwives, and nurse anesthetists were able to bill at 100%. So today, APRNs still face major obstacles in reimbursement, and we've talked about this a little bit in my previous lectures as well. So in the United States, the process is several steps. Each APRN state has their own scope of practice, their rules and regulations. You have to be able to bill and complete and document your clinical encounter with sufficient data to support the level of service that is billed. Your scope of practice, patient care must be commensurate with education and license of professional. You have to practice within your scope of practice, and you must be aware of the state laws regarding the scope of practice related to reimbursement. So your state may have something that is specific to you and how you are able to be reimbursed. You're going to get your own NPI number, National Provider Identifier. And this stays with you no matter what job you have. You're going to be registered as a national provider. APRN, then you should become familiar with the reimbursement process to ensure completion of all documentation needed to practice and bill properly. Okay. Third-party payers may have different requirements and different things. So depending on if you're in a certain specialty, etc., you may have other nuances, but you should become familiar with how does billing and coding work within your institution and your role. You're going to learn all about this as you've already discovered in your health assessment billing. There's ICD-10 and CPT codes. So remember, just like in nursing, if it's not documented, it wasn't done. This is the same thing as an APRN. The documentation considerations, one is your ICD-10 code, and then your CPT code. ICD is the International Classification of Disease, and the World Health Organization owns that intellectual property right. CPT is your current procedural terminology, which was developed by the AMA. So there's 6 sections of CPT code. There's evaluation of management, which is your straightforward routine everyday care. Anesthesia, surgery, radiology, pathology, and lab and medicine. Right? So that's why if you've been a patient, you've gotten a bill from your doctor, from your anesthesiologist, from your radiologist, from the pathology, and from maybe the medicines that you were billed for, right? They come as separate things. They're not all inclusive. Your evaluation and management codes are your provider-patient encounter. Those are the building blocks for your documentation for your encounter. Multiple codes can be used when billing your encounters, and the codes are determined by the history, the physical exam, and your medical decision making. So I'm just introducing you to some of these ideas. You're going to see CPT codes, E&M codes, etc. So E&M, evaluation and management, is part of the CPT code. And when we are providing direct clinical care, most times we're billing an EM code, evaluation and management. Outpatient codes refer to new and established patients, outpatient, so you're not in a hospital or anything that's considered an inpatient facility. You're a new patient if you've not received professional services from the physician or that group within the last 3 years. You're an established patient if you've been seen within 3 years. And then there's different codes for different level of service. So outpatient patients if you're new or established, and then each of those have their own levels of service. Inpatient hospitalization is when you're inpatient, and that's documentation from less complex to really in-depth. Your higher complexity will change your codes and you'll see an increase in your reimbursement rate, right? So if you see a 19-year-old with asthma and they have no other comorbidities and it's short and sweet and they're in and out in a day or two, you're going to be paid less for that service than you would be an 89-year-old who goes in the ICU and has multi-organ failure, right? The complexity changes how much you get paid. Subsequent hospital visits. So you have your inpatient within your first 24 hours, your H&P type of situation, and then you have your subsequent hospital visits. So progress notes, and those will show the need for further diagnostics and treatments. Your documentation will reflect your patient's status and evolution of the medical decision making, and you must document details to support your billing, your E&M code that you choose. Then you can also get into critical care codes, which are separate from your general inpatient codes. So 99291 and 99292 are specific to critical care, and these become billing on time in a 24-hour calendar day. So the first person to code for the day of your team, so if you're working with a physician or there's a day physician and a night physician, the first person within that calendar that provides the first 30 to 74 minutes of care bills at the 291. And then everybody after that would bill in increments of the 292 by 30 minutes. It's an add-on code. But again, you still have to make sure all of your notes include how unstable the patient was, the description of your complex medical decision-making included. So you can't bill and then come back at 4 in the afternoon and write rounded on patient again, updated family on labs, we'll see in the morning, and bill for another critical care code because you're not going to justify that visit. You have to have the complexity written in your note. So very quick and fast, but what we're talking about here again is that these CPT codes, you have your ICD-10, which is your diagnosis, but your CPT is the procedure that you did. And the far majority of us are within E&M codes as basic patient interaction that's outside of anesthesia or surgery. You can bill inpatient, you can bill outpatient. When you're inpatient, there's like the first 24 hours for H&P admission things, or you can then have subsequent, or you can be within the critical care. The structure. Medicare reimbursement guidelines provide direction for practices for other insurance companies. I know I've said this on previous videos. Medicare sets the tone. Whatever Medicare does, Blue Cross Blue Shield, United, etc., everybody follows Medicare. Oh, Medicare, you almost need a PhD in just to understand their reimbursement policy. So Part A covers hospital expenses. B covers medical expenses, such as physician services. As APRNs, we can only bill through Part B. C is similar to an HMO or a PPO, and D is for drugs. So people, when they sign up for Medicare, they have a choice of which ones they want to get. Everybody gets Part A, but then you have to pay a little bit more to get B, C, or D, right? So it does get a little bit confusing. People will say, I have Medicare, and then you get into their insurance and you realize they only have Part A and they don't have drug coverage, right? And so they don't actually have outpatient coverage, or they don't actually have prescription coverage. So just because someone says, I have Medicare, does not mean they're fully covered. So that can get a little confusing too. Medicare used to pay reasonable rates for work each provider documented. The scale considers 3 aspects of the work involved. Right now, so this is how they figure out how much they're paying. The physician's time, the cost of running the practice, and the physician's professional liability insurance premiums. So they look at all of that and say, how can we make sure the physicians are being paid enough to stay in practice? The scale uses mathematical calculation with a conversion factor for geographical location and reimbursement process in transition from quantity to quality. So it used to just be you build on diagnosis, you build on those things, and now there's this complex calculation that occurs that also includes patient satisfaction scores to make sure that we're giving quality care, not just care in general, but it also has to be good care. Medicaid is health insurance for low-income people, and it's funded jointly by state and federal governments. So if you have Medicaid in the state of South Dakota and you move to Florida, you have to go get Florida Medicaid. And so Medicaid is meant for people that need that next level, and it's usually based on low income, and it's also people with disabilities that end up getting Medicaid. So if someone is 25 years old and was in a horrible car accident and they're permanently severely disabled for the rest of their life, they would enroll in their state's Medicaid to pay for their health care and their room and board in a healthcare facility. In 2013-14, primary care rates increased to match the Medicare rates, which is nice. Then, as part of Medicaid and Medicare, you have CHIP, which is Children's Health Insurance Programs. So this is, again, a partnership between the federal and the state government to provide coverage to uninsured children whose family does not provide or qualify for Medicaid. So this is that gray area of you make too much money to be on Medicaid as a family member, like the mom and the dad, but they don't make enough money and they don't have health insurance for their children. They can have their children be on Medicaid. So that means also importantly that immunizations and well child care will be given at no cost. So this is our country's way of ensuring that all children will receive their care that is needed to them. There's a structure in place to provide care for all children, no matter whether or not their parents can do it. In 2015, this all kind of also went over an underhaul. And again, they started to focus on quality of care, and the Act of 2015 reformed the payment system and replaced it with a system based on measurable patient outcomes. So if you have bad scores in your practice or whatever, you get less reimbursement from Medicare or Medicaid. So if you are at an F score, maybe you get $50, but someone who's running an A+ practice can get $95, right? So that is a way to drive the person, because money talks, right? So they say if you have horrible scores and you're not having good outcomes for your patients, you get paid less. So those that are high performers will get able to recoup at 100%. Changes were called the quality payment program. So you may hear that now as well. Then for private health insurances, we still have fee-for-service plans. APRN direct reimbursement still varies by state sometimes, and the state APRN organizations can provide and help with information regarding that. Managed care contracts offer services to plan members for a predetermined, prepaid, or discounted fee, can sometimes help improve quality as well. And you're going to hear the words bundled payment. These are payments based on the expected cost for clinically defined episodes of care. This is the middle ground between fee for service and then the capitation, or being a cutoff. The strategy to reduce costs and improve quality of care and care coordination. And so this is like kind of also saying, hey, you are going to bring this 19-year-old who's otherwise healthy in for an appendectomy. You get a bundled payment. This is what we're paying, and that's it. So if you screw up and you have bad outcomes and they're there for twice as long, you don't get twice as much money. This is what you get. So you need to have good care and do it right to maximize how much money you're actually making. And this is, that's the value-based purchasing. Geez, that's more of what the value-based purchasing is that linked your quality of care to payment. So you pay for your performance, right? These all get a little confusing here. But the purpose of this is I want you just to be at least having heard these things so that if you hear this in clinical and you start to learn these things as they come up in conversation and exposure when you're job interviewing, et cetera, you have an idea of what this means. Accountable care organizations are groups of physicians or hospitals who provide coordinated, high-quality care to Medicare patients. Models are structured to ensure optimal outcomes and must demonstrate measures, reportable measures, and they have to have an EHR. So that's been mandated. This drive to have electronic health records came from Medicare. Then we have this idea of medical homes, which is designed to promote improved access, quality of care, and decreased costs. Again, a reimbursement issue is overcoming invisibility. Again, most of us are only reimbursed at 85%, even though the costs and care are the same. We have shared visits jointly performed same day between the APRN and the physician, but must have a face-to-face physician encounter, a documentation by the physician linked to the APRN note, and physician note must include one of three components of E&M. As a hospitalist, I did a large majority of my visits were shared visits. So I would go in, see the patient, manage them, do that in the afternoon. The doctor would come around and we'd go in again together. He would be face to face. He would go into my note electronically. There was a section called physician, so it was on my note, and they would do their own documentation of EMM, and we would bill it at 100% as a shared visit. Incident 2 means incident to services of the physician. So this is like if you are when I was in cardiology and we were both seeing patients the same day. So he was in the building with me. So he was there. He'd already seen the new patient and had established the new problem. And then I was doing follow-up, and they were available, and the physician performed services at the frequency that reflects active participation. So I could bill at 100%. It was a big pain in the butt, to be honest with you. But again, I had to do it because I needed to be able to reap enough money to justify my position being there and me to be in that role. So advanced care planning codes are new. These are CPT codes added to address the need for understanding and discussing the end-of-life care. So I bill, obviously, in palliative care an ACP code all the time. Service can expand and accelerate process of identifying their wishes. So we're now being encouraged to have these conversations, and they are encouraging it financially. Now I am allowed to bill for it. Transitional care codes are also new, that they can say to be billed at, trying to keep them from going back to the hospital. And so those are kind of new billing options as well. Again, there's this change from quantity of care to quality of care, and it's important that you understand those things well. I also wanted to point out there's a section in this reading that was titled Mitigating Malpractice Claims, and I wanted to make sure that we talked about that as well, and I forgot to put this in as the slide. So hopefully you as an APRN will never need this, but it's you have to have it. And obviously, the best defense is a good offense. So being well-versed will help avoid potential litigation. I don't want to go through all of this whole thing. So you do want to make sure that you have risk mitigation strategies. So you always want to use current evidence-based guidelines, practice updates, and stay within your scope of practice. Obviously, if you fall out of your scope or you don't do guideline-directed care, you're at risk for putting yourself out there for a bad outcome. Engaging in accurate and clear documentation practices, so making sure that your documentation reflects all phases of the medical treatment, the plan of care, and medication should be timely and objective and include your diagnostic results, the nature of the treatment, alternatives to treatment, the risks and benefits you discussed, the informed consent, and the education of follow-up and signs and symptoms. They also wanted to point out that there's the National Nurse Practitioner Data Bank that was established in 1996 to track this. But there's also this paragraph in here that says, this section cannot be concluded without discussing liability of collaborating physicians in reduced or restricted practice states and tort reform. So whether or not a collaborating physician is included in a malpractice liability claim is dependent on the facts of the case, the involvement of the collaborator in the patient case, and the state law. So liability risk is highest when the nurse practitioner is an independent contractor or employed by the physician. And the liability risk is the lowest when the APRN is engaging in independent practice with a collaborator identified solely to comply with state law. So just some food for thought in there as well. So do read that over a little bit when you were reading this section. I hope that was something that stood out to you. Again, when you're in practice right now, I am not suggesting that you worry about malpractice or that you're worried about these things, right? You're working with your preceptor, but these are things that you can begin to be aware of in practice and maybe discuss with the preceptor or pick their brains or those things, and maybe not be surprised if you hear them tell you, I always document A, B, and C, and ask them, well, why is that? And I would bet that you're going to get the answer of, because I want to be thorough in my billing and make sure I cover myself legally, etc. All right, so that's the quick on reimbursement. Thanks for hanging in there.